Hi guys, this is a review of Physio for our exam 3 of HBF 3. We're going to be looking at spinal reflexes, and then we have EEGs and evoked potentials, looking at the brain. So spinal reflexes, and then looking at voltage measurements of the brain to try and look for the foci, points of seizures. But starting with spinal reflexes, basically what we're going to do is we're going to walk through a couple of different reflexes. We have the stretch reflex, we have the Golgi tendon reflex, we have the flexor and crossed extensor reflex, and then some complex reflexes and reflexes that will disappear, be present in newborns, but disappear as they age. So not too bad. Let's just get to it. So we have, what is a spinal reflex? Well, it is identified as a spinal reflex if it is basically movement in response to a stimulus that's present even if the spinal cord is severed from the brain, right? Therefore, it's a spinal cord reflex, usually very short latency, meaning happens pretty much immediately, stimulus to output of muscle, and generally we know the circuitry pretty well. We'll talk about different examples, but the flexor reflex and the cross extensor reflex are, if you step on something, you're going to pull your leg up, or step on something like painful, and then your crossed extensor reflex would be in that same situation, your other leg is going to extend. And so the two work together, especially when you think about, say, like the act of walking. One leg will contract, pull back, the other extends. So basically, our spinal reflexes are going to respond to muscle length and tension. And then, yeah, so we have, as we said, there are certain ones that are going to disappear within babies, so be present within babies and disappear. The Babinski sign is the flaring of the toes. If you put pressure on the bottom of the foot, we'll talk more about that. And then general principles describing reflex circuitry is it's stimulus dependent, so it depends on how intense the stimulus is, where it's located, the local sign, and then how long the stimulus is being applied. And those will change the magnitude of the response. All right, and then generally our reflexes are polysynaptic, meaning you have more than two neurons involved, with the exception of the stretch reflex, will be the first one, which is the first one we'll talk about. And then we have the concept of reciprocal innervation. So the idea is if you are, say, trying to pull back your leg, well, you're going to inhibit, you're going to stimulate one pair of muscles, and then you're going to inhibit the antagonist to that muscle, right? So opposite output to antagonists, similar output to synergists is reciprocal innervation, and we'll see that with all of our reflexes. And then since we're dealing with reflexes associated basically with the spinal cord, right, we have sensory information and then motor information coming out. Just as a quick reminder, we have sensory information going in through the dorsal root of the spinal cord, and the cell body of these sensory neurons is located in the dorsal root ganglion. Its axon is going to come in and synapse in this ventral horn on these motor neurons, and then these motor neurons are going to send out their efferent outgoing axons to the muscle via the ventral root. Okay, so we have a couple of different types of motor neurons we'll talk about, but overall, sensory input in, motor output out to cause the action. All right, so our first reflex is the simplest one, and yet we have the most information to talk about because it is going to allow us to understand the other ones a little bit better. But the stretch reflex is basically a length monitoring system for muscles. It's found in all skeletal muscles to some degree, but it's most developed in extensor muscles. And the example that we have is the knee jerk reflex, which is, you hit the patellar tendon in the knee, and then your quadriceps contract and your leg extends. The properties of this reflex are it's the only monosynaptic reflex, and basically you just need stretch to cause contraction of a muscle. So before we move on to what the components are, like the function of the stretch reflex is to compensate for loads added to muscle. So if you, say, are carrying something and you add extra load, aka extra weight, then these muscles are going to stretch. And so you're going to want to cause a compensation or a compensatory contraction of that muscle to deal with the fact you have extra load. Otherwise, your hand, when you add this load, is just going to flop downwards, right? Because it wasn't expecting the extra weight. So we want to be able to compensate for extra weight added to muscles, and you don't want to have to say, hey, you added extra weight. I'm going to go ahead and move my arm slightly. I'm going to contract my arm a little bit more. No, we want it to be a reflex. And so that's the first function of the stretch reflex, compensate for loads added to muscles. The second is to monitor muscle length, and this is during voluntary muscle contraction. So as we'll see with muscle spindle fibers, which we'll talk about in a second, one of the components of this path of this reflex, basically you get information on length of contraction. And so if you can basically monitor length during voluntary contraction, you've gained some proprioceptive information about where you are. All right, so compensate for loads, monitoring muscle lengths are what the stretch reflex is about, but what actually is it? So we have three different components. We have the muscle spindle, and that's located here. You can see this like highlight, it's a little bit right here. And we have, basically this is an intrafusal muscle fiber, and it's the sensory ending of stretch receptor neurons, which brings us to our second component, which is the stretch receptor neuron, which is the sensory neuron for the stretch reflex. Its body is in this dorsal root ganglion, so it's dendrites coming out, and it's on the stretch or muscle spindle to get stretch information, and then it is going to send its axon in through the dorsal root and into the ventral horn to synapse, but then it'll also send to the central nervous system to send that information up. But we just care about it synapsing on the ventral horn in terms of our reflex pathway. So once it's in, well, we'll talk more about that in a second. We're just going over the different components right now. So we have muscle spindle doing the actual sensation, which is the terminal part of the stretch receptor neuron. Embedded, the muscle spindle is a fiber within the overall muscle. And it's the end of the stretch receptor. Then we have the alpha motor neurons, and these are the output neurons that are going to cause the rest of the muscle to contract, and they're located in the ventral horn, which we see here. And then they are synapsing on what we'd call the quote-unquote normal muscle fibers, the extrafusal muscle fibers. Okay, so what's the actual pathway? We already kind of touched on this a little bit, but first off is we have a movement, say flexion of the our extensor muscle right here, and it's causing the this muscle to stretch, right? So this muscle is being stretched. Say this guy is contracting, and so this is being pulled downwards. This muscle is stretching, and or for instance, you've done the knee jerk tap, and you've tapped here, and this is being pulled this way, and so now your stretch receptors, your muscle spindle, has been activated. And so the idea here in this little graph is if you have, if this is the muscle spindle and it's not stretched, notice that the action potentials are not very high in frequency, but if you have it stretched, right, now we stretch it, the action potentials increase in frequency, okay? So we have stretch at the muscle spindle as a result of this muscle stretching. That's going to, it's attached to the neuron, the stretch receptor neuron, so you're going to have an action potential going through this neuron, and then it's going to go through this neuron, which its cell body is in the dorsal root ganglion, and then it's going to synapse on an alpha motor neuron. So synapse on these alpha motor neurons in this ventral horn, and then that's going to send its axon out to these muscle fibers right here, right? So we had this guy was being stretched, and then now we have, we say, hey, you got stretched, let's not stretch so much, so I'm going to go ahead and cause this muscle to contract, right? And so stretching versus contraction, those are two opposite things, and you could say this is sort of almost maintaining like more of a homeostatic length of the muscle. All right, so it's not too bad. Reciprocal innervation here is something we didn't touch on yet because we had the basics of the pathway, right? Muscle gets stretched, then you're going to say, hey, don't stretch as much. I'm going to have you contract so we don't continue stretching. So we have stretch, action potential, action potential, action potential, go to motor neurons. Then we're saying, hey, go ahead and cause the muscle in this region to contract, so we get back to our regular length. But I'm also going to tell at the same time the antagonist muscle to not contract, because if the antagonist muscle contracts, it's going to keep our muscle that is originating the signal from contracting, right? They oppose each other. So if you one needs to contract, the other needs to relax at the same time. So we have reciprocal innervation is occurring at the same time via an intermotor neuron or an interneuron that is inhibitory, and it's just going to send out an inhibitory signal on the motor neuron that is innervating the antagonist muscle. Okay, so you have reciprocal innervation going on in addition to the excitation of the original ipsilateral muscle, and then you also have excitation of muscles that are parallel to the muscle fiber that had the muscle spindle embedded next to it. All right, so then we have, as we said, we talked about the functions: compensate for loads added to muscles, monitor muscle length. We do have one more component we haven't touched on, just because this is like adding a level of detail that we didn't need to know originally, but we actually have these gamma motor neurons in addition. So gamma motor neurons, which you can see here, are attaching to our muscle spindles. And the idea is that they are going to regulate how sensitive muscle spindles are to stretch. Okay, so if this is our muscle spindle in a relaxed state, this is the muscle spindle in a contracted state. Notice how we've gotten kind of like a, it's now no longer under tension, right? And so muscle spindles are supposed to get, figure out if you are being stretched, right? And so if the muscle itself has contracted, then the muscle spindle is now no longer under tension. So in order to still be able to sense stretch, you need to make sure that your muscle spindle remains under tension. So you're going to have your gamma motor neurons are going to adjust the muscle spindle such that they are not like lax, don't have slack. I think slack is the right word. They don't have a lot of slack in them, such that they can still, even if the muscle's contracted, they can still be sensitive to stretch. Okay. So the idea is that you have alpha motor neurons and gamma motor neurons, right? Alpha motor neurons are the ones that are going out and they're innervating the muscle, like regular muscle, right? They're going to be activated at the same time as gamma motor neurons, such that when you do have a contraction occur from the alpha motor neurons, then your muscle spindle does not become, doesn't have slack in it, right? So that you can still sense adjust. You can still sense stretch. All right, cool. But our gamma motor neurons also located in the ventral horn, and they're just going to synapse on the this muscle fiber, the spindle muscle fiber. All right, so then what are the clinical applications of the spinal stretch reflex? So we're familiar with this guy, right? We said if you tap here, then it's going to stretch the quadriceps muscle, and it will cause the quadriceps muscle to contract. If the quadriceps muscle contracts, right, it's going to pull the leg up and your leg's going to go like that. So basically, clinical applications of the spinal stretch reflexes, you can determine disorders of the central nervous system by seeing how they manifest through abnormal stretch reflexes at different spinal levels. So for the knee-jerk one, you would know if there's a lack of knee-jerk, you might have an issue at the spinal root level, L2 to L4. And then for biceps, biceps is similar. You tap here, their arm should swing out. That would be C5. Triceps is C7. And then the ankle jerk reflex, tapping here, would be S1. All right, we were told that Parkinson's disease typically will manifest with an overactive stretch receptor. And then we were also told about clonus, which is an oscillating foot movement stimulated by an upward pressure on the bottom of the foot. So you push here, and then afterwards the foot is going to oscillate back and forth. And so this is sometimes seen in multiple sclerosis patients with clonus, oscillating foot. All right, so that was the first reflex, and that took a while, but that was a stretch reflex. Now we're going to talk about the Golgi tendon reflex. And so this one is similar in a way, but going to be primarily focused on protecting the muscle from injury. So before we get into more on what it does, it is dealing with three different components. So we have the Golgi tendon organ. And so here's the muscle, here is the tendon, and we have a whole lot of these Golgi tendon organs embedded in that tendon. We're going to need some interneurons, and then we have alpha motor neurons. The function is to protect muscle from injury, sense tendon tension. So if the muscle is like very contracted, it's pulling on that tendon, and you're going to say, hey, please stop contracting because you're going to damage yourself. And so you're going to have a reflex to basically say, relax, right? So when your muscle contracts, it's going to pull on this tendon. And then if your Golgi tendon organ is being stimulated, it's going to say, hey, I think we're getting to the point where further contraction here is going to cause damage. So I'm going to go ahead and inhibit you to say, don't stretch as much. or don't contract as much, and then I'm going to cause your antagonist muscle to contract. So we get back to more of a homeostatic like point, which is we're not maybe so contracted. All right, so function, protect muscle from injury, sense tension, tendon tension, inhibit muscle, prevent damage, and then it's going to stimulate the antagonist muscle. But the functional pathway is, here we have our Golgi tendon organ, right here. And when you have this muscle has contracted, you're going to have tension on this, and it's going to activate this Golgi tendon organ, which is synapsed with the dorsal root ganglion sensory cell, which has the Golgi tendon organ as its like end point, dendrite, at the end of its dendrite, and then it's going to go ahead and take that tension on the muscle slash tension on the tendon, and it's going to synapse on a couple of different interneurons. The first that it's going to synapse on is inhibitory interneurons, and so that would be right here, and this is meant to inhibit the muscle that is attached to the tendon. And then at the same time, you have the reciprocal effect. So you're also going to synapse on excitatory, synapse on alpha motor neurons that are, you're going to synapse on excitatory intermotor neurons, which will then synapse on alpha motor neurons, which are going to go to the antagonist muscle and stimulate them. Okay, so stimulate inhibitory interneurons, stimulate for the muscle attached to the tendon, inhibit the alpha motor neurons. So what those inhibitory interneurons are doing to inhibit the muscle attached to the tendon, and then you still have the reciprocal effect, which is you're going to stimulate the, you're going to synapse on the stimulatory interneuron, and you're going to stimulate the antagonist muscle. All right, but the idea is you're protecting yourself from excessive contraction, tension on this tendon, which, you know, if there's excessive contraction here, you're going to hurt this muscle. All right, so properties, local sign, right? The response is always local to the area of the stimulus. You have, this is actually disynaptic. We said the only monosynaptic reflex that we are learning about is the spinal stretch reflex. I believe it's the only one in general. But this one is disynaptic because you have an intermotor neuron. So we have the Golgi tendon neuron, then it goes to the interneurons, and then from there to the alpha motor neurons. And then it's activated by tension in tendon and inhibitory effect. All right, so that's the Golgi tendon reflex. Then we have the flexor reflex and the cross extensor reflex, and these work on the upper and lower limbs. And the basic function for these is pretty straightforward. You have a noxious cutaneous input, so cutaneous on your skin, right? So some sort of touch, pressure, heat, cold, or tissue damage. So for instance, this poor man right here is stepping on a piece of glass. And so you step on a piece of glass, you know, or you touch something hot, you know, from your own personal experience, you're going to draw that limb back, right? So that's the reflex overall. For the flexor part is you're going to flex your muscle away from that damage. And then you're also at the same time going to extend the cross extensor, is you're going to extend the contralateral limb. Okay, so the function is to avoid or limit tissue damage. The flexor / cross extensor reflex circuits is used in addition by higher order centers for walking and running. But starting with the flexor part of it is you have stepped on something unfortunate. It's going to send its, you're going to excite the flexors. So you stepped on something bad, dorsal root ganglion, synapse on inhibitory and stimulatory intermotor neurons. You're going to go ahead and excite the flexors. So excite the flexors right here, and you're going to inhibit the extensors so that you pull your leg away. All right, so flexor reflex and crossed extensor, flexor, contract your flexors, inhibit your extensors. You do have our intermotor neurons though, or I keep saying intermotor neurons, interneurons, so you are going to have a delay of a few seconds. And then you also have on the contralateral side, the extensor reflex occurs in these situations. And so you can see that the dorsal root ganglion axon or neuron is sending its axons here, but then you also have crossing the midline of the spinal cord going to the contralateral side to the ventral horn over there, and then you have your interneurons, and then you have this is the crossed extensor reflex, so you're going to stimulate the extensors and inhibit the flexors, but you have a delay due to interneurons. All right, so flexors, flexor reflex, and crossed extensor. You just remember that order: flexor reflex. Flexor reflex is the first one, and you're going to stimulate your flexors, inhibit your extensors, pull your limb away from the damage, and then crossed extensor reflex, you're going to go ahead and extend your contralateral limb. All right, so then we're almost done. We have complex coordination reflexes of the spinal cord. So basically, we've talked about the Golgi tendon, so stretching the tendon, muscle stretch, and now we have, then we talked about crossed or flexor reflex and crossed extensor reflex. And so those are all fairly straightforward, like disynaptic or polysynaptic or monosynaptic monosynaptic in the case of the stretch receptor. But we have some more complex reflexes. And so the one example we are given as like our first example of this, because we have the ones in the babies, but we have the stretch reflex, where you're probably familiar seeing this with dogs, right? You go ahead and you scratch their back, and then their own little leg is going to move to try and like scratch that. And so this scratch reflex is a protective reflex. It's a reflex to sort of some irritant. It gets the nerve receptors on the skin, action potential sent to the spinal cord, then you get a signal sent to the brain, and then the brain sends a message to cause your hand to move, your fingers to move, in this case, this dog's leg to move. But it's more complicated than just cause flexors to contract and inhibit your extensors, right? Okay, so then we have also the idea of spinal shock. And so basically, if you have an injury to the spinal cord, you can have a spinal shock as a state of a sort of temporary or transient reflex depression. So temporary loss of or depressed, lowered magnitude of the reflexes below the level of injury to the spinal cord. And we are told that the recovery from spinal shock really depends on how complex or how developed your like nervous system is. And so for humans, recovery takes days to weeks or months, dogs, hours to days, rats, minutes, frogs, seconds. But we are also told that recovery can result in hyperreflexia. And so basically we just have, these are a couple of different more complex reflexes. So we have the bulbar cavernosus. So if you stimulate the penis, the glands of the penis, that will cause the anus to contract. And this is the bulbar cavernosus reflex. We're also told that if you stimulate the clitoris, then on a female, then the same thing would occur. And so if you have an injury to spinal cord level above that, when you do have recovery, then within 0 to 1 days, you may have a hyperreflex present, so extra contraction of the anus, 1 to 3 days. And basically, the positive means that the hyperreflexia is present. Babinski is, stimulate, rub the bottom of the foot, and the toes spread out. This is done in babies. All right, and then flexor withdrawal we're familiar with. It's not a complicated one, that's my bad. And then reflex bladder. All right, so then reflexes in babies. Basically, we have some spinal cord reflexes that disappear after the brain exerts more control over the spinal circuits. And there's a predictable pattern in newborns. We were told about these three. So there's the extensor thrust reflex, which is supposed to be sort of a postural reflex. We have the walking reflex, which disappears about 2 years of age. So if you sort of lift the baby upright and then you like hold them, and you have pressure on the bottom of their foot, it will stimulate their legs to move. And then you have the grasp reflex, which is possibly the cutest reflex, and it will disappear around 3 months. And then you have Babinski, which disappears around 12 to 18 months. And then if it's an adult, if it is present in adults, it's evidence of pyramidal tract damage. All right, so that's it. Not too bad. We had the stretch reflex to compensate for loads added to muscles, monitor muscle length. We had the Golgi tendon reflex, which was to protect muscles from injury by sensing the tension in the tendon, saying, hey, muscle, you're way too contracted. Why don't you not contract so much? So I'm going to go ahead and inhibit you and stimulate your antagonist. Then we had the flexor reflex and the crossed extensor reflex, and that's like, hey, you touched something not good. Let's pull that limb away, and we're going to extend the other limb. And then we had scratch reflexes, a little bit more complicated, and then spinal shock. Basically, you can have hyperreflexia after a spinal cord injury, and then reflexes in newborn babies. Our walking reflex disappears around 2 months, grasp reflex around 3 months, and then Babinski reflex 12 to 18 months, and if in adults, pyramidal tract damage. All right, so that's it for that lecture review. We will take a look at the next one, and but we'll take a quick pause right here.